Now,
Yes.
Ashish.
Yes, shall we start, sir?
Yeah, I'm now starting this. Okay.
Yes, sir. Yes.
Yeah, we are now starting this program. Now shall we wait till it? So we have waited already. There is a 2:07. So
Start, sir.
I'm now starting. Yeah, I'm starting. Good evening, everyone, and welcome to the webinar of our headache subsection. That is by the headache subsections of the Indian Academy of Neurology. And my special welcome to our President and Secretary of Indian Academy of Neurology, and also I welcome to our convener, Dr. Assis, and also the 4 participants. And I hope today's session enriches us with our wide insights and knowledge, valuable insights and knowledge. So I hand over to Dr. Ashish to continue this program.
Thank you, sir. And once again, welcome all the attendees and all the speakers. Dr. Debashish, the president of IN and the moderator for this session, will be a bit late. So he asked us to start. And so for this, I would like now to invite Dr. Praveen Kumar Yadav, who is Associate Professor of Neurology at SRIMS Durgapur, West Bengal, to present the first case. Dr. Praveen.
Yes, sir. Thank you, sir, for the kind introduction. First of all, I thank IN and the IN headache subsection for providing me this opportunity to present this case. And my regards to all the seniors here. So I'll be presenting a short case of a patient who presented recently to me with headache, with fever, in fact. And it may be a bit unusual for the case to be presented in this headache symposium, but it has a close relation to headache disorders. So that is why it is being presented here. And we commonly see such patients, and there is some diagnostic, how to go about the diagnosis and how to manage these patients in the OPD. That's a challenge. So this case is being presented. So this is the story of an elderly lady who presented with history of fever. So this is the 65-year-old widower who lives alone, presented with history of fever.
Sorry, Dr. Praveen, the slides are not moving. There's just one slide. You need to probably go to the slideshow, and then it's not moving here.
Okay, sir.
Probably.
1 second. So is it visible now, sir?
Yeah, no. Thank you.
Yeah. This is the visible.
Yes, sir. 65-year-old widower lives alone, presented with history of fever since 3 months duration, which was mild in the mild fever without any chills, no evening rise of temperature. There was no associated cough, urinary symptoms, or any underlying focus of infection by the symptoms of which was present in history. This was associated with weight loss of almost 8 kgs over the last 4 to 5 months, and the weight loss was non-intentional. She was initially evaluated by a physician outside in the general medicine department. She was admitted because she was having on and off fever and weight loss for evaluation in a local hospital. And then she was evaluated there. A lot of investigations were done, and this was the discharge summary which I had with me when the patient came for consultation. So all the workup for fever was negative, apart from raised inflammatory markers. The CRP and the ESR was very high. The hemoglobin was 8.4. They had done infective workup for tuberculosis, which included the chest X-ray and also the TB Gold test, which was done, which was negative. Autoimmune profile, ANA, C-ANCA and the P-ANCA was done. CT chest and CT abdomen was done, and ultrasound KUB, which was all found to be normal. The urine routine and the cultures, everything was found to be normal. She was given empirically with many courses of antibiotics for the refractory fever, but there was not much improvement in the fever. She had mild headache that was 3 months back, that is just prior to the admission. during the onset of the fever. It was a holocranial, non-throbbing headache lasting for up to 1 hour without any nausea, vomiting, photophonophobia. There was no other associated symptoms along with the headache. The headache lasted for 2 weeks and then it subsided on its own. And it occurred daily for 1 hour for daily 1 to 2 attacks, and it lasted for 2 weeks. And then it was subsided because of the history of the headache. She was evaluated during her admission itself by the physician. MRI brain plain plus contrast was done, which was found to be normal. There was no evidence of any structural lesions or meningeal enhancement. And a CSF was done after the MRI, which was again, which showed a normal evaluation. The TB PCR was done and the ADI was also done in the CSF, which was again normal. So this was the history, and because they could not find out the cause of evaluation of the fever, she was discharged after that. And she also had a past history of diabetes, was on insulin with metformin and SGLT2 inhibitors with good control of the sugars. There was no history of high sugars at that time. Now she was having the pain in the neck and the arms. So she thought that it may be something related to neurology, and that's how she came to the OPD for evaluation. On taking the history, at that time, there was no headaches, there was no visual symptoms, there was no history of any neurological symptoms either in the cranial nerves or in the weakness of the limbs or any other focal neurological deficits. She had generalized body pain, but on palpation of the joints, there was no history of, no joint swellings or history of any synovitis. There was jaw pain, which was there on chewing, especially in chewing the food. She used to have intermittent jaw pain, which was present right from the onset of the illness. She was severely feeling very much fatigued and she felt tired most of the times. So this was the thing. And an examination, the BP was 140/80. The pulse rate was normal, regular. There was mild pallor in examination. There was no clubbing, no skin lesions. The patient was conscious, otherwise oriented. Higher mental functions appeared to be normal. And the neurological examination was overall normal. The cranial nerves and the motor system, the power, the sensory system, and the reflexes, plantars, everything was normal. There was no neck stiffness. There was no scalp tenderness anywhere. The temporomandibular joint appeared to be normal. Fundus examination was normal. And sinus, there was no tenderness. On examination, there was a prominent superficial temporal artery, which was seen more on the right side compared to the left side. It was mildly tender, but it was pulsatile. There was no nodularity in the artery, and the pulses were well felt. And on the shoulder joint, there was pain, and on the movements, the pain, the movements were painful. The range of movements were, however, full, and there was no evidence of any arthritis in the upper limbs, distally, proximally, anywhere. So this was the examination finding, and you can see the temporal artery appears to be dilated in this patient, and it was mildly tender, though pulsatile. So to summarize, she had a pyrexia of unknown origin evaluated without a cause. There was weight loss of 8 kg, which was non-intentional. There was body ache, especially in the proximal part with jaw claudication, and initial headache, which recovered on its own, though she was not given any treatment for the headache, and it lasted for 2 weeks. Workup for infection, autoimmune, and malignancies, etc. was normal. The MRI and the CSF study was normal. And on examination, the positive finding was a temporal artery which was swollen and pulsatile, as well as some stiffness of the proximal joint. So these were the positive findings from the history and the examination. So I proceeded with the re-evaluation of the patient. The hemoglobin was done, which was 7.8. The WBC count was 7,800. Neutrophils 80%. Platelet count was bit high, 5.2 lakhs. ESR and CRP was very high. ESR was 85 and the CRP was 90.5. The peripheral smear showed a normochromic normocytic anemia. Renal function test, liver function test were normal. Albumin was bit on the lower side, 3.2. Because she had proximal pain, so to rule out some myopathy, CPG was done, which was normal. Sugars were normal, 120/172. HbA1c just mildly elevated of around 7.2. So because of this history of raised ESR and CRP with a painful temporal artery, which was prominent, and history of proximal joint pains, so I thought of a diagnosis of temporal arteritis. And so directly went for the investigation, that is the temporal artery Doppler, which are done by a few radiologists in this region. Since it's a small city, so this investigation is not commonly done, but some of the radiologists do it well. So you can see this is the temporal artery Doppler of this patient, and you can see this is the flow in between the vessel, and there is a hypoechoic area around the artery, both the sides. So this is called as the halo sign, which was reported by the radiologist as the halo sign. And this is the report which has been given, in which she has suggested that there is bilateral temporal arteritis with moderate narrowing, right more than left, with more tortuous left superficial temporal artery. So suggestive of a bilateral temporal arteritis. So the diagnosis was almost certain temporal arteritis. She was advised biopsy, though it is not locally done here. So we could have sent her to a tertiary referral center for a biopsy. So, but she did not want to go because there were no responsible caregivers who could take her and bring her back. So she was empirically started on oral prednisolone, 60 mg OD. And after 7 days, though the symptoms dramatically improved, the fever disappeared, she felt very well, appetite improved, the body pain subsided. Overall, the patient was very happy with the introduction of the steroids. But after 7 days, the sugar started to increase. So it became more than 300, was seen by the dietitian. Insulin was increased and she was added on dapagliflozin along with the other medications. And the patient was very happy, but the only issue was the high sugars which she started developing. So because on the dietitian insisted on reducing the steroids, so it was reduced to 40 mg after 2 weeks. Still sugar was 300. Again, the dietitian was not happy because insulin was being given at a very high dose and they did not have much medications to add to control the sugars. So I was forced to reduce the Vislon to 20 mg. Now, as the other options for steroid sparing agents, so tocilizumab was the best option, though it is not used much here after the COVID times, and the patient was not affording for a very expensive drug. So the other drug which was tried in this situation was methotrexate, which came in my mind. So, and we use it quite often for rheumatoid arthritis. So this was started at 10 mg weekly and then continued like that. Now the patient is on 20 mg steroids daily and also weekly methotrexate along with folic acid. The sugars is high, but still within the, it's not very high. So fasting is around 190 and PPBS is 240. So this is the story of the patient, and in 4 weeks time, she has improved, and the CRP and the ESR was again repeated, and the CRP has come down around 10 and the ESR is around 40. So there's improvement in the blood parameters as well as the patient is showing subjective improvement. So this was a case of temporal arteritis which presented as PO and evaluated, and later on the headache was again not the prominent presenting manifestation, and it had PO with some polymyalgia rheumatica like presentations. So if we go through the history of temporal arteritis, so there are a lot of pictures which depict this disorder. So it was known in the ancient world also. You can see the person having a very dilated temporal artery, and blindness was again depicted in some of the pictures. Because of this disease, many people had become blind. So it is known to the mankind since long, and we all know it's a large vessel vasculitis involving the large and the medium vessels. And it can affect the cranial vessels commonly and also the aorta and the greater vessels. And it is a disease of the elderly, so occurs after 50 years of age. Why it occurs in the elderly is not very clear, being an autoimmune disorder. And it is the most common idiopathic systemic vasculitis which occurs in the elderly population. Systemic symptoms are very common, and it depends upon the blood vasculature which is involved. And usually the carotids and the aortic branches, aorta or its branches are affects, and it can cause aneurysm, stenosis of the involved blood vessels, and even can give rise to strokes due to the involvement of the carotid and the vertebral arteries. Now the risk factor, the most commonest risk factor is age. So age is the commonest risk factor. However, there are certain population-based risks, like in the Scandinavian countries and the North American population, it has the highest incidence, followed by the Southern Europe and the Mediterranean countries. However, the African, Latin American, Asians and Arab population are the low risk population. It is more common in female with a ratio of 3:1. and it has some MHC HLA-DR B1404 allele, which increase the susceptibility for the disease, but not the severity of the disease. And also some viruses and bacteria like Mycoplasma, Chlamydia, and Parvovirus may have a role in inciting the autoimmune process, as we have in many other vasculitis like Takayasus, where tuberculosis is said to be one of the causes. Now, this is the superficial temporal artery, which takes the brunt of the disease in the temporal cranial variety of the disorder. So you have the frontal, the parietal branches, and the various other branches. So depending upon the branches which are involved, you have the symptoms of the patient, whether it is headache, visual loss, or jaw claudication, which takes the prominent part in the clinical manifestations. It presents with a lot of manifestations. The systemic manifestations are also there. Headache is the commonest symptom in 75%. Jaw claudication is a very specific symptom. Then polymyalgia is an important presentation, and it usually presents to the rheumatologist. Then fever, weight loss, and fatigue. So these are non-specific symptoms, and the patient may land to the physicians as well. And unless there is a high index of suspicion, the diagnosis of giant cell arteritis may be difficult to make. So more awareness about this disorder in the elderly population is needed. Ocular manifestations are the most catastrophic manifestation, and it may give rise to visual loss. So that we have to look out, and once the diagnosis is confirmed, immediately steroids should be started to prevent any visual loss, especially in the cranial presentation of giant cell arteritis. Then diplopia, visual hallucinations are there. Vascular manifestations are very fatal. It involves the aorta, and it can present with aneurysm, dissections, and all. One thing we have to remember is that the vascular manifestations can only present with systemic manifestations like fever and these manifestations. And you have to do focused investigations like CT angiogram and MR angiogram to detect the aortic involvement. And one more thing is that even in the remission, the aortic aneurysms may form. So these patients has to be monitored, especially if the aorta is involved initially. You have to follow up the patients with the ESR, CRP, as well as vascular imaging to rule out any development of the aortic aneurysm. And CNS involvement, vertigo, ataxia, dysarthria, neuropathy, and transverse myelopathy has also been mentioned, but it is very rare. So this is the frequency of the manifestations. You can see weight loss, malaise, and fever can be seen in 30 to 40% of the patient. Polymyalgia rheumatica in 40%. Synovitis. One more thing is that it may mimic a late onset rheumatoid arthritis. So you may have actual joint involvement and swelling in some of the patients. So do not be surprised if there is an inflammatory arthritis also. So, but you have to work up for the rheumatoid arthritis, including the RA and the CCP, RA factor and the CCP has to be done if there is any doubt. And headache is a very important symptom. Jaw claudication I've already mentioned. Then if the aorta and the branches are involved, then you may get a limb claudication like symptoms. Especially it may look like a Takayasu arthritis with the limb claudication. However, the age of presentation may be different because Takayasu occurs before 40 years and this occurs after 50 years. And then arterial tenderness and bruising and all, like we see in the Takayasu, may also be seen if there is a large vessel involvement. Now, headache is one of the classical symptom, and it usually occurs over the temple, but it can occur in the frontal, occipital. It can be unilateral or generalized. The headaches can be progressively worsening, or it may wax and wane, and sometimes it may recede before the treatment, like in our patient, in which the headache was very brief and lasted for 2 weeks. And it is the commonest presentation, and the quality of the headache, there is no defining characteristic. The only thing is that it's a new onset headache. So elderly patient with any new onset headache, you have to think of this condition. And you have to ask the history properly because it may be transient and it may improve over a period of time. Now, visual loss, it is a very important cause of permanent visual loss, and the most important cause is arthritic anterior ischemic optic neuropathy. It can also cause CROA, BROA, and also posterior ischemic neuropathy, and also strokes and involving the occipital cortex may be an important cause of visual loss. So these are the causes, and the most important is AION, that is 88%. And PION in 3%, CRAO, BRAO, and choroidal infarctions and optic atrophy due to unclear mechanisms are also there. Now, AION is the most dreaded thing which can occur in 85% patients of causes of visual loss, and it is due to the involvement of the posterior ciliary artery, which is a branch of the ophthalmic, and the internal carotid artery. So this involves the extradural arteries only because there is the internal elastic lamina in these arteries, and the intradural arteries are usually spared. So that is the logic behind it. And most AION is non-arthritic because many of these patients may have a atherosclerosis, like this patient had diabetes, hypertension and all. So many of the patients may have atherosclerotic disease also. So it's very important to differentiate arthritic AION and non-arthritic AION in this, especially in this group of patients, because of the common vascular risk factors which may be there. And this may be a very important cause of referral from the ophthalmologist. They may refer to us to find out whether it is arthritic or a non-arthritic AION. And so the differentiating features are the non-arthritic ARON is usually, it has a male and female equal predilection. The jaw pain and jaw claudication and the headache is not very prominent. Visual loss is not very severe in non-arthritic AION. And there is improvement in up to 43%. So they have a visual loss which is not very severe, and then it improves partially in non-arthritic, while in arthritic AION, usually there is a not much improvement and the visual loss is very severe. And also, if you look at the disc, in it is a non-arthritic AION, it's a hyperemic disc and the cup is small. So smaller cup with a hyperemic disc, while a pale disc with a normal cup is seen in arthritic AION. So with these findings, we can definitely differentiate in most of the cases whether it's arthritic or non-arthritic AION. And if it's arthritic, then you have to go for the steroids for the management. While in non-arthritic, usually steroids may worsen the other parameters. So it's better to avoid steroids in non-arthritic AION. Now, the risk factors of visual loss is age, hypertension, thrombocytosis, and jaw claudication. So these are the important risk factors. And prior transient visual loss, sometimes they may just present with amaurosis-like symptoms. So if there is a transient visual loss which improves in a patient with GCS, so immediately you have to give the patient steroids to prevent a permanent visual loss. So that's an emergency situation. Now, diplopia is a non-specific but important manifestation, and it has been found to be very commonly seen in this condition of giant cell arteritis. So you should ask history of diplopia, and it may be due to involvement of the brainstem, the nerves, or the extraocular muscle themselves. So the mechanisms may be different. Now, coming to polymyalgia rheumatica, this is one manifestation with which the patient can go to the orthopedicians, rheumatologists, and the general medicine people. So they have pain and morning stiffness about the shoulder and the hip girdles in the neck and the torso. 40 to 50% of the GCA have PMR, while 10% of the PMR patients may develop a GCA. Now you can see this is the distribution of the joint pains in the proximal parts, and it is symmetric, and early morning stiffness is there, and there's a gelling phenomena. Like in the morning, they will feel that the entire thing has gone into a gel-like thing. And there's nocturnal pain also, and sometimes there may be a non-erosive arthritis which is involving the hands. So it's an important manifestation, and it may have multiple differential diagnoses. For example, you may think it's a fibromyalgia because again pain is very common there. Hypothyroidism, polymyositis like presentation, it can have pain and weakness, but there will be neurological weakness, while in PMR the neurological weakness will not be there. Malignancies can present with such manifestation. Occult infections can be there. Late onset spondyloarthropathy, rheumatoid arthritis in the elderly can present like this. And very important is diabetic patients and the elderly people may have the frozen shoulder, cervical spondylosis and all. So this may be mistaken by as a non-inflammatory degenerative arthritis. So do not take this symptom easily, especially in an elderly patient who has a lot of systemic symptoms. The pains should be evaluated with at least the inflammatory markers. Constitutional symptoms are again are quite common: fever, fatigue, and weight loss. Fevers in 50%, it is low grade, but in 15% of the patients, there may be a very high fever. So it may have a misdiagnosis of infections. And anorexia and weight loss are usually minor, but may be significant. 10% only fever and raised CRP and ESR. So you should have a high index of suspicion in this 10% of the patient, and 15% of PO in elderly are due to giant cell arteritis. So any PO in elderly without any cause or focus, you should look for giant cell arteritis. An older adult with fever or constitutional symptoms not explained by an initial evaluation of infection or malignancy, always keep this diagnosis in mind. Now coming to jaw pain, this is a specific symptom of the giant cell arteritis, and 50% of the patient will have a jaw claudication due to involvement of the internal maxillary artery in the facial artery which supplies the maxillary muscle. And this symptom has a positive correlation with the temporal artery biopsy. So if you look at the biopsy positive correlation, then you can see jaw claudication and abnormal temporal arteries on palpation. and polymyalgia rheumatica has a good correlation with the positive biopsy findings. Now, giant cell arteritis can present with two patterns. One is the cranial predominant pattern and one is the large vessel arteritis. Cranial predominant pattern involves the extradural cranial vessels like the temporal arteries and ICA and the ophthalmic branches, etc. So it has a different set of manifestations and it presents usually to the neurologist and the ophthalmologist initially. Then they present with the classical features which we know about, and a biopsy is usually positive, and the Doppler, that is the color ultrasound Doppler, is positive in these patients. Now, the large vessel is the challenging group of patients where it becomes difficult to diagnose. Usually, they are biopsy negative because the temporal artery is not involved. The color Doppler is negative and it becomes difficult to diagnose. So, you have to do the PET, CTA, MR angiogram, and there may be polymyalgia rheumatica like presentation in this group of patients. So, you should have a high index of suspicion, especially for the large vessel arteritis pattern of the giant cell arteritis. And the clinical features: large vessel presents with limb claudication, asymmetric BP, abnormal radial pulse, or vascular bruit. Like we see in the Takayasu's arteritis, the findings will be similar to that. Only thing, they may be a bit younger also. For example, 68 years, and the constitutional symptoms are less and fewer headaches and jaw claudication because the temporal arteries are not involved. So the pattern of manifestations may be different in a large vessel arteritis. So these are the differential diagnoses which we keep into mind. One is vasculitis, rheumatological conditions like Takayasu's. However, the differentiation is younger age in Takayasu's, less than 40 years. Renal involvement is more common. It causes renal artery stenosis more. Less polymyalgia rheumatica in Takayasu's, and visual loss is not very common in Takayasu's arteritis. And in the elderly also, there may be atherosclerosis and atheroembolism, which may be important thing because of the vascular risk factors the elderly population usually suffer with. Malignancies, especially lymphomas, and infections. And one infection, that is tuberculosis and subacute bacterial endocarditis, are said to be the commonest mimics of giant cell arteritis, and a echocardiograph should be done if there is if the elderly patient comes with PEO. Usually echo should be done before we say that it's a large vessel involvement of the giant cell arteritis. Now, this is the 1990 ACR criteria. We all know this: age more than 50, new onset headache, temporal artery abnormal, and you needed a biopsy for diagnosis of temporal arteritis according to the 1990 ACR criteria. But there is a change now. This is the classification criteria by EULAR, that is in 2022, which says that the age should be more than 50, which is an absolute requirement, and you have additional criteria and they have a scoring for these things. So you can see +2 for morning stiffness, visual loss +3, jaw claudication +2, new onset temporal headache +2, scalp tenderness +2, and abnormal examination of temporal artery on palpation +2. And you can see the investigations which are there. CRP and ESR is +3, and there is positive temporal artery biopsy or halo sign in temporal artery ultrasound. So both are kept as equivalent in this diagnostic criteria, and it is very important for us because we have a non-invasive test which can be done and which may be used instead of a temporal artery biopsy, and it has a +5 score. So, and also FDG PET and axillary artery Doppler is also included in the criteria. So with this classification criteria, without a biopsy, you can diagnose a temporal artery, giant cell arteritis by doing the ultrasound, color ultrasound Doppler. However, it is an operator dependent thing, and the expertise of the radiologist becomes very important. Now, specificity of ESR and CRP, almost 5% of the people may have a low ESR. So ESR may not be very specific. And also with the increasing age, ESR increases, there may be anemia, CKD, which may affect this. So the CRP is a more sensitive marker and has a better negative predictive value in this group of condition, and it correlates with the temporal artery biopsy better. And also the platelet count may be elevated, and it is more said to be more specific than that of the CRP. Now, this is the biopsy picture which shows a transmural pan layer involvement of the giant cell arteritis. One thing is the length of the biopsy should be 1.5 to 3 centimeters at least. The biopsy may be negative in 42 to 61%. So it is not a very, very specific, very, very sensitive investigation, though it is specific. And fibrinoid necrosis is extremely rare. So if you get a fibrinoid necrosis, then you think of alternative causes of vasculitis, which may be giving rise to the symptom. Now, the timing of the biopsy is very important. If there is a sudden visual loss and irreversible visual loss, immediately give steroids. Do not wait for biopsy. And the biopsy can be done later after 2 weeks, because the biopsy remains positive after 2 to 4 weeks, even after giving the steroid. So that is not a major concern. And sometimes if the biopsy is negative, then you have to do the contralateral side biopsy in 5 to 15% of the patient. With the advent of the Doppler, the biopsy now has become a bit less, especially in areas where it is not widely available. So the color artery Doppler is a good investigation, and for large arteritis, you can use PET, CT, CTA, and MR angiogram. And this is a color artery Doppler, and there's a classical sign called as halo sign, which is due to thickening of the vascular lumen, and it is said to be very specific. The thickness of the halo has to be taken into account, 0.3 to 2 millimeter. It should be there to say that it's a positive halo, and it has a sensitivity of around 67 to 77% and specificity of around 80 to 95%. And there is something called as a compression sign or lack of compressibility of the halo with external compression of the vessel by the ultrasound probe. So this may be again a good accompanying finding along with the halo sign. Now, ultrasound of the Doppler is now the first investigation which is being used for temporal arteritis. It is non-invasive, easy to perform, quick with absence of radiation, relatively lower cost, and also helps in to direct a biopsy wherever required. And these are studies which meta-analysis which shows that the halo sign is has a good weighted sensitivity compared to that of the biopsy. So it's a good investigation which is available. So you can see this is the halo sign seen bilaterally. And also there is thickness and tortuosity and stenosis of the arteries, which may be picked up with the ultrasound. Now there is a halo score also, which is developed by the rheumatologist, in which they use the thickness of the arteries in the 4 arteries, that is the superficial temporal, parietal temporal, frontal temporal artery, and the axillary artery, and these scores are added together. And so this score is getting standardized, and this can be used by radiologists to grade the halo, and it may be a very useful objective measurement. And this is the PET CT scan in which the wall of the artery showed an increased uptake. So this is again for the large vessel variant. And MR angiography and the CT angiography is there. These are all very important and useful investigations. Now coming to the treatment, last 2 minutes, I'll just, I think I'm exceeding time, so last 2 minutes. So glucocorticoids are the mainstay of the treatment, and then glucocorticoids with tocilizumab and glucocorticoids with methotrexate are the other options which are available. Now, glucocorticoid controls the systemic inflammation, protects ischemic optic neuropathy, and the symptoms improve dramatically with steroids. But the drawback is the vascular complication, especially the arteritis, do not respond much to the steroids. The relapses may occur with the steroids, and also the plethora of side effects, which we all like in our patient, which may make us to reduce the dose of the steroid or to stop the steroids because of the unavoidable and the serious side effects. Now, the dosage of steroid is, if it's uncomplicated GCA, 0.7 mg per kg, they are around 40 mg. And if it's a complicated GCA with visual involvement or aorta involvement or with a major organ involvement, then 60 mg per day is the classical dose. It may be used as a single agent, which was initially, and IV steroids may be given if there is a sudden irreversible severe visual loss due to AION. You may pulse the patient with 3 to 5 days of steroids. Now, this is the initial dosage, and you taper the dosage of the steroids as we do in other conditions based on the symptoms and the CRP in the ESR. And this taper has to be continued for a period of 6 to 12 months. Now, if it is a polymyalgia rheumatica, you can go a bit faster in the taper of these patients. Now, the toxicity of the steroid is the main issue. You know all sort of toxicity it can cause. So there are adjuvant treatment of steroid sparing agents, and there are randomized controlled trials of methotrexate, which are positive, and tocilizumab, which is again positive, and abatacept. So I think methotrexate will be useful for because it is available as oral preparation, and we are much familiar with the use of this drug. So there are studies which shows that methotrexate prevents the relapse of the first relapse by 35% and the second relapse by 51% in the patients who have started on giant cell arteritis, and also it reduces the cumulative dose of the steroids which are being used for this patient. So it has a steroid sparing effect, and it reduces the relapse as well. And the dosage is similar of that what we use in rheumatoid arthritis. Now, this is a landmark study of tocilizumab for giant cell arteritis. It is called the GIACTA trial. And here the tocilizumab was used weekly 162 mg or twice alternate weeks 162 mg along with a steroid taper of 6 months. So here what they did, they give a combination of both, and steroids were stopped at 6 months, and the tocilizumab was continued for 1 to 2 years. And they found that the relapse recurrence rate was reduced in both the groups by almost more than 50%. So it is more effective than methotrexate in reducing the relapses. But the other things are like it is costlier, the side effects are there, and especially in our place like in a developing country like ours, it may not always be possible to use tocilizumab in this group of the patients. And this is the ACR guideline, which again says the same thing. And if the tocilizumab doesn't work, then you can go for abatacept, which may be a good agent in this group. So I think I've already explained this. So unexplained weight loss and fever and proximal joint pains always work for GCN in an elderly patient. Temporal artery Doppler is a key investigation in the diagnosis in giant cell arteritis, and it may be a very useful investigation, especially in expert hands. And glucosteroid is the main treatment, but in the elderly patient not tolerating it, methotrexate may be a useful add-on therapy in giant cell arteritis patients. So thank you for the patient listening.
Thank you, Dr. Praveen. Sir, please. Sir. Dr. Ganguly.
Yeah, thank you, Praveen. You have discussed very clearly and very exclusively the temporal arteritis infection. Regarding but 25%, there is some eye involvement like other temporary or permanent diplopia, blurring of vision. It is a 25% can occur, but you explain everything. There should not be any questions. You discuss everything in detail. And definitely one have to, and the infection, you mentioned this thing, one thing during COVID sessions, the COVID infections, SARS-2 infections, they sometimes make just these presentations like presentations. Now, Ashish, you can discuss anything, or we have to switch over to other.
No, sir, I just, I forgot to mention all the attendees. If you have any question, please put it in the question QA box on the app. So please, if you have any questions, please come forward. Dr. Pradeep, Dr. Praveen, I just have one question. So how do you monitor when you are with such a patient? When you are reducing the steroid dose, so how do you monitor them? What frequency you should get the ESR, CRP done, and how do you monitor them?
According to recommendation, they say monthly, at least monthly, you should get the ESR, CRP. First ESR, CRP should be done after 2 to 3 weeks. And then thereafter, once the patient responds, we have to do it every month. And also the symptoms of the patient has to be evaluated. And if it's a temporal artery arteritis with a temporal artery involvement, you can do the Doppler at least every 3 months so that you can see whether the thickening and the halo sign is improving or not.
And how long will you continue steroids? For example, in this patient, you started methotrexate early, probably because of the toxicity. The patient was developing high blood sugar.
Yes, sir.
But otherwise, how long? When will you start methotrexate, and how long will you continue methotrexate and steroids in this?
Sir, according to the guidelines, they are not very clear what to do. Like in the American guideline, they say you start with steroids and tocilizumab because it is widely available there. So they say you start with that only. While in the other guidelines like the French and all, they say you can give steroids as a single agent and then continue it up to 1 year. And then based on the patient's response, you stop and reduce it. Sometimes the recurrence may occur, almost up to 30% may recur. And if while reducing the steroids, if there is a recurrence and the patient is not tolerating well, then you can add a steroid sparing agent like a methotrexate or tocilizumab during the recurrence.
And then how long will you continue the steroid sparing agent then?
So 1 to 2 years, sir. So 1 to 2 years. 1 to 2 years.
And is there any role of interleukin-6 monitoring in giant cell arteritis?
Yes, yeah, because it's this tocilizumab is against interleukin-6. So they say that it is more specific than CRP, but it may be very expensive to be used repeatedly. So that is why they do not recommend it.
Thank you, Dr. Praveen. It's an excellent talk, and you discussed all the points pertaining to giant cell arteritis. So it's a rare diagnosis, but once in a few months or year, neurologists see this, and it's an important topic for all the neurologists. Thank you.
Thank you, sir.
Thank you, Praveen.
Thank you, sir.
Sir, sir, shall I call the next speaker? Dr. Ganguly?
Definitely call the next.
So the next talk will be by Dr. Kumar Vismaya and Dr. Soumyadarshan Naik. Dr. Kumar Vismaya is a senior resident, post-DM senior resident at CG Medical College and Hospital, Behrampur, Odisha. And Dr. Soumya is the associate professor and head there, and he has completed his fellowship in headaches at Australia, Sydney. So, over to Dr. Kumar Bismaya.
Thank you, Dr. Ashish. I'll let Kumar present the case first, and then we'll have a discussion.
Yeah. Thank
Very
you.
interesting case, and not to be missed. Bismay, please continue.
Am I audible, sir?
Yes,
sir. Good evening, respected teachers.
Put on the PowerPoint mode.
Sir. Just a second, sir.
Bismaya, can go to at the bottom. There is a
play.
Yes, sir.
I think just left to that. You can put on F5 and or you can go from view slideshow from there.
Okay, sir. Okay, sir.
Top there is slideshow, na?
Hello. On your menu bar, sir, there is the option of slideshow. On your menu bar, top menu bar.
Top.
There is the option.
In the
top menu bar. There is the option of slideshow.
Yeah. Just there.
Yeah. Go further.
To the right.
Yeah.
Slideshow. Before that. Yeah.
Okay, sir.
From beginning. Click on the from beginning. First option.
First option.
Not that, sir. On
first
your
option.
left side. On your left. Yeah.
Thank you. Good evening, respected teachers. It's an honor to present a case on this platform. I'm thankful to the organizer and our HOD sir for giving me the opportunity to present this case. The title is A Tale of a Dangerous Headache Not to be Missed. So we have an 61-year elderly male presented with headache for last 20 years and drooping of left eyelids for last 3 years. Coming to the headache, patient had a headache which was insidious in onset, dull aching, waxing and waning. It was affecting the left side of the left hemicranium of mild grade of VAS score 3. It was partly responsive to analgesic, and associated with intolerance to bright light and sound. But last 4 days, patient had acutely worsened his headache, his severity gone up and to VAS rating of 8. It was sharp shooting type and persistent throughout the day, involving the left-sided, predominantly orbital, retroorbital, and frontal area, associated with vomiting. There was no diurnal or postural changes, and it was not related by any analgesics. It was not associated with any lacrimation or any redness, and no history of any head injury was there. He also had drooping of the left eyelid after 1 day of worsening of his headache. It was complete drooping, and he was unable to move his left eyeball in either horizontal and vertical direction, and it was associated with double vision in all direction. It was not associated with any numbness over face or any diminished in vision. There was no history of any limb weakness, tremulousness, incoordination, head injury, or any ear discharge. So patient, his past history suggestive of he is a known case of rheumatic heart disease with severe mitral stenosis with atrial fibrillation, and he has undergone mitral valve replacement in 2003. And currently he was on oral anticoagulant, acetone 3 mg, and he was recently detected as diabetes with poor glycemic status. On summarizing, an elderly, newly detected diabetic male presented with subacute onset left hemicranial headache with acute worsening and left-sided complete ophthalmoplegia without any diminished vision, facial numbness, limb weakness, incoordination with past history of rheumatic heart disease with severe MS and atrial fibrillation on oral anticoagulation. So on localizing, we thought in view of headache, acute worsening of headache and left ophthalmoplegia, most common site is we thought about of cavernous sinus because of involvement of third, fourth, and sixth cranial nerve, but there was no facial numbness or any tingling sensation over the trigeminal distribution. We also thought about the superior orbital fissure involvement of 3, 4 in view of 3, 4, and 6 cranial nerve. Orbital apex also involved 3, 4, 6, but there was no involvement of second cranial nerve, and other than that, patient did not have any history of any proptosis or any feeling of pressure behind the eye. We also thought about subarachnoid space, because sometimes patient having an aneurysm can present with acute headache with ophthalmoparesis, especially third cranial nerve palsy. So our differential diagnosis were vascular with cavernous sinus thrombosis, some aneurysm. We also thought about carotid cavernous fistula, though less likely because there was no history of any conjunctival redness, there was no history of any exophthalmos, but because of second, third, fourth, and sixth cranial nerve, we also put it into our differential list. We also thought about infection because the patient was recently detected to be case of diabetic with diabetes. So we also thought about fungal sinusitis and also meningitis. We also thought about inflammation, especially Tolosa-Hunt syndrome, because of subacute history. And sometimes, very rarely, sarcoidosis can also present with headache with ophthalmoparesis. We also thought about ophthalmoplegic migraine because though patient did not have any prior history of any headache, but subacute onset of headache and with history of ophthalmoparesis within 2 weeks, we also thought about ophthalmoplegic migraine, and other rare causes. We also thought about pituitary apoplexy. But unfortunately, on the day 3 of the admission, patient suddenly became drowsy and he was disoriented to time and place. He had a history, fever spike, and it was associated with neck pain, and his blood pressure dropped up to 80 to 60. But there was no history of any cough, chest pain, or any breathlessness. We reviewed our differential diagnosis, and we thought it could be due to new onset stroke because patient has already on oral anticoagulants. We thought about it could be an brainstem bleed, or it could be top of the basilar artery syndrome. Patient developed altered sensorium. But we also at that same time ruled out other differentials like inflammation and ophthalmoplegic migraine, and we moved ahead with following differentials. On general examination, at the time of admission, patient was conscious. GCS was 15 out of 15. Blood pressure was 130/70. Pulse rate was 86, but irregular. Patient was in atrial fibrillation. The rest of the general examination were non-significant. Coming to the CNS examination, GCS was E4, V5, M6. Second cranial nerve, visual acuity, field of vision, and fundus were normal. Third, fourth, and sixth cranial nerve, there was complete ophthalmoplegia, left-sided complete ophthalmoplegia. Pupil was dilated and not reacting to the light. And fifth cranial nerve was normal, both sensory and motor. The rest of the motor examination were normal. He had decreased sensation below his ankle, and left ankle joint were absent. This is the investigation on the day 1. As we can see, his creatinine was 1.6, sugar was 238, HbA1c was 12.3, and PTINR was 1.78. Echo was suggestive of severe MS post mitral valve replacement with atrial fibrillation, and ultrasonography of abdomen and pelvis suggestive of grade 2 medical renal disease. The patient was sent for CT scan, and in the CT scan, as we can see, there is a hyperintense lesion just in front of the midbrain, probably in the suprasellar region, which is extending towards the left side of the orbital apex. Left side. Coming to on day 3 of the admission, as I have told, the patient became drowsy, disoriented. GCS became E3, V4, M5. Blood pressure was 80/60. Pulse rate was 96, irregular. Vision could not be tested because patient was in a state of altered sensorium. Neck stiffness was present. And the day 3 of the examination, the routine examination, there was no much changes. The creatinine was 1.5 and HbA1c 12.3 and PTNR was 1.82. The patient was immediately shifted to ICU. Hydration was maintained judiciously in view of his mitral valve stenosis and atrial fibrillation status. Other neurosurgery, endocrinology, and cardiology consultation was given. Sample was sent for hormonal assessment. Anticoagulation was stopped, and injection hydrocortisone was started, 200 milligram IV start, and then 50 mg 6 hourly. After 72 hours, patient GCS improved and his vitals were stable. After that, we sent the patient to MRI. And in the MRI, as we can see, there is a well-defined iso-intense lesion just in front of the midbrain. And in the T2 section, we can see there is an lobulated mass in the suprasellar region with some hypointensities, probably because of necrosis or some bleed. Or in the flare also, we can see there is hyperintense lesion. In the sagittal section, we can see clearly there is a suprasellar mass, and this is the, we can see in the pituitary section, this is the pituitary gland. It is significantly swollen, and there is significant contrast enhancement, and it is abutting towards the left side cavernous sinus. The MR angiography and MR venography were normal, although there are some hypoplastic transverse sinus left side. The orbit was normal. There was no any orbital mass, and we can see there is some mucosal thickening, and there is some fluid collection in the right side, the opposite side, right maxillary sinus also was there. And this is the GRE sequence. As we can see, there is a blooming in the suprasellar region, and it is extending posteriorly to the interpeduncular fossa up to the third ventricle, and in the both lateral ventricles also. So there was some bleeding involving to the third ventricle and up to the extending to the lateral ventricle. So the hormonal assessment on the day 3, as we can see, the TSH were low and ACTH was less than 5, and serum cortisol was also low. That probably this is explaining his fall in blood pressure. We don't have the image of the patient at the time of admission, but this is the image after 2 weeks, and as we can see, there is some residual ptosis on the left side, and his medial rectus, lateral rectus, each movement is restricted, and depression is also restricted on the left side. So our final diagnosis was rheumatic heart disease, severe mitral stenosis, post-mitral valve replacement with atrial fibrillation, newly detected diabetes with diabetic kidney disease, with diabetic peripheral neuropathy, with pituitary macroadenoma, with bleeding leading to pituitary apoplexy and IV extension. So patient was discharged with injection regular insulin, bisoprolol was added 2.5, and acetron was started after 2 weeks in a lower dose. Tablet hydrocortisone was given 10 mg BD, and thyroxine was given at 50 mg. So now coming to the pituitary apoplexy. Pituitary apoplexy is a life-threatening emergency condition. As definition, any acute infarction or hemorrhage into pituitary gland is called pituitary apoplexy. In 80% cases, it is due to pituitary tumor, most commonly a non-functioning adenoma. In rest of the 20% cases, it is due to non-adenomatous conditions like hypophysitis, craniopharyngioma, any Rathke's cleft cyst, or cellular tuberculoma, or cellular mets, or Sheehan syndrome. But Sheehan syndrome is not synonymous with pituitary apoplexy. In Sheehan syndrome occurs because of postpartum hemorrhage. There is cerebral fall in cerebral perfusion leading to infarction of the pituitary gland, causing Sheehan syndrome. So if we see the clinical feature, the most common symptom is in pituitary apoplexy is headache in 95%, diplopia in 78%, vomiting, visual field defect, and impaired visual acuity. This visual field defect and visual acuity, this occurs because when the cellular mass, it becomes swollen, it compresses the optic chiasma, so leading to visual field defect, most commonly bitemporal hemianopia, and it also can give rise to altered sensorium in 5 to 10% cases. If we look into the endocrine dysfunction, there are 80%, in 80% cases, there is enteropituitary hormone deficiency is seen. Most commonly, it is central hypoadrenalism leading to hypotension or hemodynamic shock. Gonadotropin deficiency and thyrotropin deficiency is also been seen, but not acutely, after months later. And if hyponatremia has also been explained because of inappropriate antidiuretic hormone secretion or because of severe hypoadrenalism. If we look into the pathophysiology, the most commonly this pituitary apoplexy occur in a case of pituitary macroadenoma. So in case of macroadenoma, there is significant increase in the demand, metabolic demand, increase glucose uptake and increase amino acid uptake. And the blood supply, the vascularity has been compromised. So the vessels are not, vasculogenesis is not rampant. The vessels are also fragile. That is the reason the patients, these pituitary adenoma are prone to either infarction or hemorrhage. And the predisposing factors are oral anticoagulants, any dopamine agonist, estrogen therapy, surgical intervention, brain injury, or hormonal stimulation test, especially in endocrinology, if they are providing any releasing hormone, gonadotropin releasing hormone or corticotropin releasing hormone, that can stimulate its metabolic demand and give rise to pituitary apoplexy. In our case, the patient was on oral anticoagulant. That is a risk factor for developing hemorrhage. So there is a score called pituitary apoplexy score. There are 4 components: level of consciousness, visual acuity, visual field defect, ocular paresis. So this score helps us in guiding the patient, because there is controversy whether the patient, these kinds of patients should be treated conservatively or should be treated surgically by decompression surgery. So as per this score, the total score is 10. And if the score is 4 or more, as per the UK guidelines, they are suggesting transpyramidal decompression surgery should be considered. The components are level of consciousness, visual acuity, field defect, and ocular paresis. Now coming to the management, I would just like to highlight. So these are the indications when patient has a severely reduced visual acuity or severely deteriorating visual field defect or deteriorating in level of consciousness. These are the conditions where patients should be shifted for neurosurgical intervention and transpyramidal decompressive surgery. Otherwise, patients should be managed conservatively. So the take-home message is patient with pituitary apoplexy should be considered in any patient with abrupt neuro-ophthalmologic deterioration associated with underlying headache. Absence of visual impairment does not exclude pituitary apoplexy. It depends whether the mass, supracellular mass, going superiorly and compressing the optic chiasma, or it is growing laterally and compressing the cavernous sinus laterally, leading to 3rd, 4th, and 6th cranial nerve. So visual impairment may not be present all the time. As in our case, on the day of admission, patient did not have any visual impairment, but after immediately one day, patient become mentally, his sensory was decreased, so we could not test the visual impairment. But when the patient improved, when we rechecked, the patient had bilateral temporal hemianopia. So, and patient with oral anticoagulants, if developed headache and ophthalmoplegia, pituitary apoplexy should be considered. So my conclusion is the pituitary apoplexy is a serious medical emergency and it requires multidisciplinary approach. Optical management of pituitary apoplexy is still controversial. Some prefer conservative management. Some demands for any aggressive neurosurgical intervention. Surgical decompression is considered when there is a visual field defects and rapidly progressive field vision is there, or any deterioration of mental status. And the pituitary function test should be assessed later on. Thank you.
Thank you, Bismay. And I think we wanted to make it we sent a clear message. This pituitary apoplexy is a very serious condition which neurologists rarely deal, especially these cases which present as Sheehan syndrome. They present to either the gynec department, followed by endocrinology or the medicine people. So we get cases which are not Sheehan's, pituitary apoplexy. These conditions are very, very rare. You get it in at least 1.8 to 2.6% of pituitary macroadenomas. Especially when we have cases presenting with unilateral localizing headache of subacute to acute onset with neuro-ophthalmologic manifestations, especially cranial nerve deficits with or without this optic nerve involvement. So we should keep this entity as a differential. And we should be very rapid in assessing as well as investigating the patient, lest the patient goes into a shock and we lose the patient. Mortality is very high. We were lucky to have the patient in-house and we could investigate him and we could have him referred to a proper ICU setup. The only problem at this teaching institute is that we get dates for MRI, and we had the MRI done only after the patient was stabilized. So I think Bisma has made it very clear how we went on for localization and how imaging revealed the bleed and all. So especially when this bleed percolates to the interpeduncular fossa, and it compresses the midbrain and the pons, and there is some intraventricular communication, there's bound to be loss of sensorium. And luckily we had a patient who recovered. Management he has already outlined, so I think we are open for question now.
So, Dr. Ganguly, sir.
Thank you for beautiful presentation. In any acute headache with visual disturbance, especially frontal headache, even the atypical facial presentations with pupillary affection, ptosis, we should think of pituitary apoplexy. That is because it's a life-threatening condition, and if we treat promptly, that in that case, that your intervention, early intervention, shape the life of the patient. Now, is there any relations you are now stressing over there's a mitral stenosis and there is a atrial fibrillations, whether there is any relations with that or it is a separate entity?
Absolutely, sir. Actually, this RHD, rheumatic heart disease, is a separate entity. But in a middle-aged male, when we retrospectively see that he has a suprasellar mass, the most common presentation for pituitary apoplexy is bleed into this tumoral mass due to oral anticoagulants. If you leave aside the Sheehan's group, Sheehan's are those peripartum cases who present with pituitary apoplexy. Apart from that, oral anticoagulants, if the patient is already on oral anticoagulants, you have to be careful if he has an underlying pituitary tumor. Usually, these patients, as Bisma indicated by our score, the pituitary apoplexy score.
Yeah.
Yes, sir. So the crux is if you have this optic nerve compression, then you have to go for some surgical intervention. Otherwise, the patient will go blind. But if the patient does not have optic nerve involvement, no compression, no chiasmal compression per se, then we can go conservatively. And usually endocrinologists prefer this conservative method, and you have to stop oral anticoagulants, even if it affects the cardiac, this clot formation is affected. You have to stop oral anticoagulants for at least 2 weeks. Guidelines are now recommending at least 6 to 8 weeks oral anticoagulant stop. But again, it is $1 million question. The cardiologists want an early oral anticoagulant start. And I think actually the problem, what caused the bleed was his this renal impairment, recent diabetic status, and there may be other risk factors like some infection which predisposed him to bleed. So he was doing okay with his indolent tumor, but this recent change in status, glycemic control, renal, maybe some infection or so, because he had minimal pyrexia at presentation. We also kept the possibility of some fungal sinusitis, but once we saw the tumor and bleed, immediately it was pituitary apoplexy.
Oh, how long in this case? How long you have stopped this anticoagulant in your
2
case?
weeks. We took a cardiology consultation. We had a discussion with them, and we stopped for 2 weeks, sir. So actually, he had a very tight this mitral stenosis. Already, he had undergone mitral valve replacement, and
2003.
yes, sir. So they did not want stoppage for a longer period. But
I,
AHC recommendation is you can go up to 6 to 8 weeks and you can stop oral anticoagulants. But usually that is not the case. So usually we stop maximum for 2 weeks. 14 days is the maximum limit. Usually what we stop.
yeah.
And
Fungal, why you think though there is a presence of history of recent diabetes, you think is it fungal? I think it's
uh,
unlike a fungal one from the history because it is a
yes, sir.
devastating fungal is a devastating things. And also the carotid cavernous fistula, there is a carotid buoy and sudden onset and also proptosis will be there.
Absolutely, sir. Fungal we just kept in the DD because of his recent uncontrolled diabetic status. And but once we had this imaging showing this tumor, and it was leaning on to the left side, the only thing was his vision was not affected at presentation. He came with this dull headache, and after maybe 15 to 16 days, 2 weeks, he came with this left-sided ophthalmoparesis. At that time also, when we examined, his vision was not affected. And later on, when we examined after recovery, his vision only he complained of diplopia. There was no visual obscuration as such. That actually saved the patient. So we treated him only conservatively.
Yeah, thank you very much. Astis, have you any questions or any questions in the chat box?
Yes, sir. There are two questions for Dr. Soumya. So, Dr. Vasudeva has asked that if there is no history of anticoagulation, the patient has a stable cardiovascular status. So, how would you differentiate this pituitary apoplexy from Tolosa-Hunt syndrome?
Bisma, would you like to answer?
So this pituitary apoplexy, it is the onset is very acute onset, because it is an sudden onset severe headache with ophthalmoparesis. But in Tolosa-Hunt syndrome, the patient usually they come with an acute to subacute history with headache with ophthalmoparesis. And but in this case, the patient has a very acute onset. Though he had some previously some headache that is non-specific headache, but the day patient presented with acute severe headache, followed on the very next day patient developed complete ophthalmoplegia. So in Tolosa-Hunt, though it can the duration is little bit more subacute.
So actually what happens is in pituitary apoplexy, headache is a presentation in at least 95% of patients. In Tolosa-Hunt, it is actually the retroorbital pain with ophthalmoparesis. It is not a typical headache. Pardon? Yeah. So Tolosa-Hunt, they present with one type of headache. And it's usually this retroorbital pain with ophthalmoparesis. Here in apoplexy, we have a changing character of headache. It's a hyperacute condition. Patient may present with systemic features of this hypotension. Then patient may present with loss of consciousness, and he may have to be landed up in the ICU. So this is not the case with Tolosa-Hunt. It's usually a indolating course, and it's a very clean-cut diagnosis. There's no headache component per se.
So, Dr. Soumya, there was another question. What was the tumor finally? Was it excised?
No, sir. I think Bisma will answer that.
No, sir. The tumor has not been excised. Patient is currently only on medical management only, conservatively management only.
So, what's your future further plan for that?
The plan is we have to look for the repeat MRI to be done after 3 months to see whether the size has been reducing or not, or is there any other significant compression still persisting or not. And then the next plan will be, we will do the next plan as per with the neurosurgery consultation.
Okay, thank you.
The
So, yes,
yeah,
Dr. Sam. Sorry,
yeah.
please continue.
The guidelines are not very clear, but if there is no optic nerve involvement, then it is a conservative management which is followed as per the criteria we have shown. And we can wait and watch, because usually the tumor shrinks after infarction and all this bleed. So we have to do serial MRIs. Usually every 3 months we do MRI. If the size has reduced, there's no need of surgery as such. The patient will require long-term hormonal replacement. And if the tumor persists after 3 or 6 months, then we can go for a transpinoidal or a direct approach, craniotomy.
Thank you, Dr. Soumya. So there were a few questions for Dr. Praveen as well. One was how long to continue methotrexate in maintenance therapy. This he has probably answered. And another was, if Doppler confirms halocine, do you still do biopsy? This also is answered, but I would like Dr. Praveen just to elaborate on that. Dr. Praveen? Anyways, he had mentioned it when the new criteria, it's the biopsy and the halocine are interchangeable. So Dr. Debashish has just joined. So welcome, sir.
Thank you. Sorry for joining late. I don't know. I mean, the traffic was so bad and I had a problem. So anyway, how far we are?
We have presented 2 cases, sir.
Right. Right.
There were a few Q&As. So the first case was a giant cell arteritis. So that was presented by Dr. Praveen.
Right.
And there was a question that if the Doppler confirms halocine, do you still do biopsy?
Pardon, I didn't get the question.
Sir, if the halocine is positive on the ultrasound, do you still need a biopsy?
Okay. Right. So what do you think? I mean,
sir, Dr. Praveen had presented the new ULAR guideline diagnostic criteria 2022.
correct.
They mentioned that biopsy and halocine both have equal points, either a halocine or a biopsy. So if a biopsy is not possible and a halocine is present, then that can be taken as...
Yeah, so I think that one caution needs to be maintained here, that if you are getting a halocine, then of course that's good. Then that becomes a more predictive of the diagnosis. But sometimes what happens that you just get a atherosclerotic or stiffening changes in the muscle, arterial wall, in the arterial wall. And sometimes people interpret that as inflammatory reaction, because I've been seeing of late some of the ultrasonologist reports that they are saying that inflamed, kind of a wall of the arteries. That should not be taken as the only, kind of evidence for diagnosis, because these people are elderly, these people are having a lot of other associated comorbidities also. So stiffened or thickened arteries, or there is some inflammatory changes in the arterial wall, will not definitively say that this is temporal. But if you are getting a halocine, because a halocine is significantly suggestive, because it is showing that there is a possibility of a luminal occlusion and a partial luminal occlusion, and that you can see also the reversal after treatment, So we had one case in which initially, in fact, the involved side artery was, we could not actually see the artery on USG, but later on when he started recovering, then we got the halocine, Then when the patient started recovering, then we got the halocine. So halocine is important, but it has to be contextualized and seen that in what context you are getting. But of course, if I think that for elderly patients who are coming with headache, then if you you are having a arteritis, then you should always start. Then you can. Hello. Yeah. Am I audible?
Yes, sir. Yes, sir.
Okay. So, did you talk about some of the recent developments about the treatment part? I mean, besides the steroids, the use of tocilizumab.
Yes, sir. Tocilizumab. Yeah, Dr. Praveen. Yes, sir. Tocilizumab was discussed. The trial, the JACTA trial,
Yeah.
which was published. So that was discussed.
Right. Okay. Okay. So I think that still in India the giant cell arteritis is underdiagnosed, and I think high suspicion, high suspicion index is needed. So Dr. Suchita said that she could not hear my hello sign comment. So I said that if the hello sign is there, typically then it is obviously very, very suggestive of a giant cell arteritis. But if you just get the wall thickening or arterial wall, some vague inflammatory changes, which is often reported now by the sonologist, you should should not solely depend on that. Then you might have to do. And the problem with the biopsy is this, of course, that all of us know that it can be a skip lesions, and therefore, even if you do the biopsy, it might be non-rewarding. So my take would be that whenever you are having a suspicion of giant cell arteritis, give steroids. Don't hesitate to give steroids. Give steroids the earliest opportunity, and then see the response. Normally, if you give steroids, then about 90% of the patients will respond within 3 to 5 days. So their headaches will dramatically, vanish, and then you can, decrease the dose. If they don't, then obviously you have to look for other causes. So we have had patients like that where we had not clinched the diagnosis, but on suspicion of the clinical features, we have started the steroids, but the patient did not respond after 3 to 5 days. So then we have to had a review. And I remember one was, of course, a patient who had a mimic of the giant cell arteritis with a kind of a cardiac cephalalgia kind of a pain, right? So he was actually, that history came much later, that he was actually having this pain while doing exercises and walking and all that thing. So, but someone possibly got the jaw claudication history and started with a giant cell arteritis diagnosis. So therefore, I think you should have a very low threshold of starting steroids. And of course, now if things are available, then if the patient are not responding to steroids, then you can think of tocilizumab. And the second case?
The second case was a pituitary apoplexy. A patient who presented with acute onset headache and then developed ophthalmoplegia, and there was a macroadenoma and the pituitary which had bled, and then he developed hormonal insufficiency. Okay. It was presented by Dr. Bismaya and Dr. Soumya.
Okay.
Hello, sir.
Hello, Soumya. So,
yes, sir.
Anything new in pituitary apoplexy? You kindly, I might have missed something, so you can educate me.
No, sir. It was actually a middle-aged male, actually, who presented underlying rheumatic heart disease. So he presented with subacute onset of headache, left-sided, and over a few days, after 2 weeks, he had this ophthalmoparesis without optic nerve involvement. And luckily, we had admitted him. And in ward, he developed hypotension and he collapsed. So before we could go for an MRI, so we had to admit him to ICU, and we managed him conservatively. We took all this into account. What could be the possibility of an orbital apex mass presenting acutely with this without optic nerve involvement? Because initially it did not have any optic nerve. It was a complete ophthalmoparesis per se. So, and later on, he had this hypotension and adrenal insufficiency.
Okay.
CT scan provided us the mass, and there was a hyperintense suprasellar mass and
But
hyperdense
this
mass.
ophthalmoparesis was not preceded by a thunderclap. During that time, there was no thunderclap
No,
headache.
no, sir, no, sir. He had this dull type of headache presented to OPD, and he went away with some medications, and he later on returned with ophthalmoparesis. We actually admitted him for evaluation purposes, and in hospital he crashed. So that
Okay.
actually was the clue that this hypotension, all these, it may be a suprasellar mass with bleed. We searched into all this pituitary apoplexy, which was the non-Sheehan's group. And there we found that the most common cause of bleed is this oral anticoagulants. Where it causes bleed in 90 to 95% of patients with a underlying pituitary tumor. And this patient had this bleed, and the bleed actually communicated to the ventricles also. So he had some meningeal signs, some fever, all these things. And
Yeah.
we actually managed this patient conservatively. And as there was no optic nerve involvement per se, we discussed about this pituitary apoplexy score, and his score was actually less than 4. So we did not go for any operative intervention. We managed him conservatively, and he has actually recovered and he is doing well. So that was the case, and we have already started him on hormonal replacement. All his this hormones, cortisol levels were low, so we had to start him on hormonal replacement. And now his this ophthalmoparesis has gradually recovered. So the take-home point was this: any patient presenting with neuro-ophthalmologic signs and with underlying anticoagulation, so you should be worried that there may be an underlying mass, a pituitary mass, suprasellar mass, which may
Yeah,
bleed.
yeah. So I think that group, this is a common kind of condition where you have or aunt might have caused this. And of course, as you rightly said, that anticoagulation is a potent this thing, but sometimes it may also happen because of other conditions as well. So that is why it is an uncommon condition. Therefore, the suspicion index should be high, I think.
Yes, sir.
And especially if you are saying that there was no kind of a thunderclap kind of a presentation, so therefore it becomes even more difficult to
Yes, sir.
diagnose before imaging the pituitary is
Absolutely, sir.
involved. Right.
Yes. It wasn't a
Very good.
thunderclap
Excellent.
presentation, and he had this diabetes, uncontrolled diabetic
Yes,
status also.
Ashish. Yeah, absolute cases of where thunderclap presentation of pituitary apoplexy. So I think one patient probably died and rest all were okay.
Absolutely, sir. Very fatal condition.
Any other case or two cases were there, Ashish?
So the third one is to be presented. Ashwin is going to present the third one. Next case.
Okay, go ahead, please.
Am I audible?
Yeah.
Yeah, Dr. Ashwin, Associate Professor Tebas. So Dr. Ashwin is now going to present his case. Thank you, Ashwin.
Actually, sir, I'm an assistant professor at IVAS.
No problem.
Good evening, everyone. It's been a very intriguing discussion about two very rare cases where high suspicion needs to be made for diagnosis. But I move on to a simpler case where the nuances are a little difficult. I thank the IAN subsection for the opportunity to present this case today, and I convey my regards to my teachers, Dr. Debashish sir, Dr. Ashish sir, and other seniors on the panelists. So I'll move on with the case. Is the screen? Yeah. So so the objectives of today's case would be to discuss the diagnosis, the pathophysiology, and discuss the treatment guidelines, because I think um, as a treating clinician and neurologist, the diagnosis is still not properly fixed. So I would like to discuss this with the panelists here also. So the case actually goes on like this: a 44-year-old male without any comorbidities or any substance abuse, no other significant past histories apart from the fact that he had a tooth extraction and a root canal therapy. So in 2021, the patient had a tooth extraction and a root canal therapy. After that, a chronic pain started, and it started from the site of the tooth treatment. That was the upper maxillary area on the right side. It happened almost every day without any remission, and it's been chronic for almost 2.5 years now. The pain lasted for around 20 minutes to 3 hours, and on a VAS scale, the patient would say that it is a 10. So now, what are the pain characteristics that the patient presented to us with? You can see, I think you can see the diagram that I've tried to make. The pain starts from the upper maxilla, and then initially, when it started after the tooth extraction, 3 to 4 months after that, the pain started from the upper maxilla. Then the pain radiates to the lower jaw, and then it radiates to the periorbital area, as shown in the figure of the side profile of the patient here. So it begins from the upper maxilla, takes around 10-15 minutes to reach the periorbital or the retroorbital area or the temporal area. And once it reaches there, it stays there for around 1 to 3 hours. And it is associated with prominent autonomic features like restlessness, conjunctival tearing, facial edema, rhinorrhea, nasal stuffiness. There is no touch sensitivity. There is no triggers to this pain. There is no sensory loss. Over the next 2.5 years, the patient had some treatment, which we will discuss in the further slides. But over the course of the next 2.5 years, the pain now predominantly occurs in the right periorbital area. The radiating nature of the pain from the maxilla to upwards is now less. It happens around 2 to 3 times a day, and the autonomic features still remain prominent. There is no periodicity as such, as in the patient does not say that the pain wakes him up in the night or it occurs at a specific time in the day, but it does occur 2 to 3 times a day now. When the excruciating pain relieves, sometimes he has a mild dull aching pain in the area wherein he had the radiating pain, that is the jaw. So, before I move on to the differential diagnosis, I would say that the patient, when he came to us now, he was having this kind of a pain, and on examination, we found that the fundus was normal, the cranial nerves were normal, there was no sensory loss, there was no touch sensitivity, the extraocular movements were normal. The rest of the examination was also normal. We did an MRI imaging along with the FASTA scan. There was no lesions in the pituitary area. There was no pachymeningitis. There was no compromise of the neurovascular bundle near the trigeminal nerve. So since we've ruled out majority of the secondary causes, we thought that yes, it's a primary headache, and the topmost would be a chronic cluster headache, because the patient did fit into the symptoms did fit into the criteria: more than 5 attacks, very severe unilateral supraorbital or temporal pain, 15 to 80 minutes, and he had conjunctival injection, rhinorrhea, facial swelling, and eyelid edema, and a severe sense of restlessness. And the frequency was also almost every other day, 2 to 3 times. A second thought that came to our mind because of the initial origin of the headache was that probably it's a combination of cluster and trigeminal neuralgia together, which is called a cluster tic syndrome. Now, described first time in 1994-96 in neurology. They said that this can have 3 types of pain. One can be a trigeminal neuralgia type, one can be a cluster type, and one can be one where both of the things are combined. So although it was not a paroxysmal burst or a lancinating kind of a pain, this radiation, but still atypical trigeminal neuralgias are heard of, which are known as TN type 2, wherein there is a continuous pain rather than interspersed paroxysms. So this was the second diagnosis that we thought, but we proceeded to treat him as a cluster headache because In the last 2.5 years, he's been treated for trigeminal neuralgia outside. Carbamazepine was given. Lamotrigine was tried. Both of them together were tried, but he had never any relief with this medications. So he stopped them. He went to some other doctor, and there he was treated for paroxysmal hemicrania. Indomethacin was also tried. So since our work was a little easy coming downstream 2.5 years, and having a better idea of the pain, we thought that it is cluster headache, and we started him on the treatment, and we started him on verapamil 240 milligram per day. And since he had some sleep issues, we gave him melatonin also. For acute prevention, we told to keep him an oxygen cylinder and zolmitriptan nasal spray, which to be taken on the contralateral nostril. Prednisolone was added as a transitional therapy. And since he had severe headache, very severe, and this was affecting his daily to daily life so terribly, transitional therapy of unilateral gone block was also used along with this. I would say probably the treatment of both prednisolone and unilateral gone block may not have been chosen together, but we decided to give it because of the extreme pain that he was having. So now what happened is that after these things, the transitional phase for the next 2 weeks, the number of attacks were only 2, lasting for only 10-15 minutes, and then again the increase in the attack episode starts to happen. And gradually from once in 3 days to now 3 to 4 days by almost April 12th. So now April 12th, since the steroid short course was over, the other option was to try another gone block. So we did give him that. Verapamil was increased. Melatonin was then made 10 milligram per day, and topiramate was also added. The current status is that the pain is almost similar. But he now starts to use this nasal spray, zolmitriptan nasal spray, and oxygen at home. And if he uses it as the pain starts, his pain subsides within 10 to 15 minutes, or else it goes on till 2 to 2.5 hours. He says that occasionally he has this jaw pain now after the settlement of the excruciating pain. And as per some case reports and series where gone block can be repeated even before a month, we have tried it again on 29th, that is yesterday, because he got again admitted on the Sunday, and because of the severe pain that he was having despite the medications. So now the points of discussion is whether we all agree with the fact that it is a cluster headache post an endodontic treatment, or is it cluster tic syndrome, or it is something else, atypical facial pain which has a tack-like behavior. Because these days, the idea of trigeminal autonomic cephalgia as being one entity because of the pathophysiology is also prevalent, which we know in the case of Sankt and Suna. So maybe this is something like that. So, but just searching the literature for cluster tic syndrome, there was a large cross-sectional study in 2013 by Donnet et al. 244 cluster headache patients they included in the study. They found that 5% had trigeminal neuralgia along with cluster headaches. Most of those cases had an ipsilateral trigeminal neuralgia involving the V1 distribution. Some of them had a V2 distribution also, but none in the V3. And there were no triggers. I mean, the trigeminal neuralgia in these patients did not have a trigger. There was no intraoral or touch sensitive in these patients. 70% of the time they occurred together with cluster headache, but there can be a situation in these 25% of the patients where both of them occur independently, and in some also contralaterally. So, ICHD 3, where you study about cluster headache, the diagnostic criteria is given. They also mention cluster tic syndrome, and they say that you treat these two conditions separately. And for cluster, you treat cluster, and for trigeminal, you treat trigeminal neuralgia, probably giving a better chance of improvement. In this series, they actually treated the patients only with verapamil. They treated cluster basically, and they found out that 40% of the patients did improve. The trigeminal neuralgia also improved along with this treatment. So now moving on to cluster headache, just a few points before moving on to the pathophysiology, which actually I want to discuss. So, cluster headache, it's a very severe pain. The pain is more than labor pain, peritonitis, and kidney stones. There are suicidal ideations during the attacks, happen majorly in men who are between 20 to 40 years of age. Most of them are episodic, 80 to 90%. The minority, that is around 10 to 15, are chronic. Chronic means that these patients have headache without a remission for more than 3 months. Episodic, at least 2 cluster bursts, which are separated by more than 3 months of remission. So unfortunately, this patient did not have any remission period as far as him concerned in the last 2.5-3 years. So we have labeled him as chronic. So moving on to the pathophysiology, in this case, because the patient had a dental tooth extraction, and prior to that, and I know this question might be coming into many people's minds that, when these kind of patients, specifically trigeminal neuralgia, comes to us, neurologists, we think that the tooth was removed erroneously, the messenger was shot. But in this case, there was no pain prior to the tooth extraction. There was a mild pain in the maxilla itself, no cluster-like pain or no trigeminal neuralgia-like pain. So it was extracted and cluster started. So let's look at the physiology, how cluster headache happens. It has got two theories, a peripheral and a central pathophysiology. These three are listed as the peripheral harbingers of cluster headache. Cluster sinus, cavernous sinus involvement and vascular theories have now been debunked because of lack of evidence. So trigeminal nerve involvement, in a sense that the trigeminocervical complex, trigeminal nerve supplies around the vessels, the trigeminal autonomic reflexes, and the trigeminal spread or the stimulus to the higher centers like thalamus and hypothalamus. This is a figure that is taken from a Nature Primer 2013. You can see that if there is some mechanical or nociceptive input from the face and the neck, so includes the face and the neck, if there is any nociceptive input, it goes via the trigeminal nerve, goes to the trigeminal nucleus caudalis, and along with the C1, C2, this forms the TCC, the trigeminocervical complex. So from here, it can give an input to the salivatory nucleus, superior salivatory nucleus, and via the sphenopalatine ganglion, it causes the autonomic features and vasodilation, which again creates a loop of sensitization and pain. This trigeminocervical complex also relays it to higher center, bringing into the theory of the central involvement, which also, especially in cases of cluster, when we see that there is rhythmicity, it happens in autumn, it can happen at a particular time of the day. So of course, we think that yes, central involvement is there. So pain networks, hypothalamus, and other brain areas also play an important role. So from the same paper, Nature 2013, you can see that various other areas like the raffinucleus, locus ceruleus, periaqueductal gray matter, hypothalamus, thalamus, amygdala, prefrontal cortex, anterior cingulate cortex, the insula, they all play a role via pain pathways or via upward stimulation from the TCC. So these two pathophysiologies are mentioned for cluster headache. Now, what are the causes for cluster headache other than the central one? See, when we as neurologists deal with cluster headache, we know that tax, notorious, pituitary area regions may be notorious, the hypothalamus may be involved, there might be some cavernous sinus involvement, there might be pachymeningitis, there might be compromise of the trigeminal vascular bundle there, some compression causing these kind of pain. But when we search the literature for cluster headaches reported from other than neurologists, like ENT specialists, dentists, and endodentists, we came across very interesting case reports. Herein also, they have mentioned a lot of patients who presented with cluster headache type complaints. And these are all case reports, the things that are highlighted underneath, they are all case reports wherein periodontitis or caries or impacted molar tooth, even foreign body in maxillary sinus and paranasal sinusitis have caused cluster-like features, and on removal of these, pathologies or inciting factors, the cluster headache has actually subsided in these patients. So this is one aspect of it, that a patient might have a cluster-like headache and a tooth is removed erroneously. The patient might have a tooth pathology presenting as cluster headache, and if the tooth is removed or that area is removed, the cluster headache might subside. This patient is actually the third type. So here he did not have a headache, no issue prior to that, but he had an endodontics. So this paper that was published in 2011, they have taken actually 54 patients of cluster headache. And then retrospectively, they've searched the records for any dental procedure. So they found out that 60% of the patient had a tooth extraction or some endodontics like a root canal therapy or something in the same quadrant or the same area where the pain has occurred, like in our patient, right-sided tooth was removed, right-sided cluster headache happened. But 1/3 of these patients also had a procedure on the contralateral quadrant. And the pain cluster headache originated after 1 to 54 months. This is the range. Average was around 14 months. So now, why does this happen? So interestingly, As we had mentioned that there are afferents which take the pain sensation to the TCC. So in cats, what they found out that if the non-myelinated pain fibers, the C-type fibers, or the nociceptive fibers, which are present in the pulp, the dental pulp, if they get amputated for some reasons, the afferent signal starts to change, and this causes a trigeminal neuronal activity via functional and morphological changes in the trigeminal nucleus of in the spinal area. So basically, the deafferentiation causes an increased sensitivity and sensitization to pain. Although this is not proved in humans per se, the functional and morphological changes, but this, along with the idea that the superior alveolar nerve of the maxillary division of the trigeminal nerve does secrete substances like substance P, which also leads to inflammation and sensitization of the pain, can be one of the causes why the patient after post-endodontics might have a trigeminal neuralgia-like pain, which on recurrent sensitization then stimulates the hypothalamus or the thalamus and then converts probably into a cluster headache. This is what we thought, and we've treated him for cluster headache as of now. So as far the treatment guidelines are concerned, I said, we probably might have gone a little overboard when we treated him, because as a clinician, it gets really difficult to see somebody in pain. So sometimes you think that whatever you have, arsenal, you utilize it on the patients. Although the guidelines actually say that there is no use of an additive, there is no additive effect, unlike cases of epilepsy where you can have additive medications. It does not. So these are the two latest guidelines that I've put for your perusal. There's a small infographic. It talks about
Ashwin, can you just summarize this thing, because I think already half an hour is passed for your lecture. Can you just be brief and summarize?
Okay, sir. I'll just summarize. I think I just wanted to discuss a couple of things that in acute, oxygen can be used. We all know. Use a non-breather mask. And since you cannot carry it around, triptans can be used, but they can also be used, twice a day maximum. So as far as the European guidelines is concerned, subcutaneous sumatriptan 6 milligram if available can be given, or else nasal sprays olmitriptan 5 or 10 milligram is better. Preventive verapamil is the first choice, has moderate effect, can be started from 360 to 1200 milligrams. There is a latency when you give 2 to 3 weeks. There is a latency. To avoid this latency, transitory treatments like steroids or Gon block can be given. So you can start at 240, wait for 2-3 weeks, then increase 80 milligram every 3-4 days. And once 480 milligram is reached, for every 160 milligram increase, do an ECG. You do an ECG before verapamil starting, you do the same for this. Lithium is also there. I've just highlighted two things, that since it's difficult to maintain the narrow therapeutic window, some people use it the last. Topiramate and valproate are the other second and third line drugs for the same. This is the small summary of recommendations. And these are the two transitory treatments. Steroid, short courses are given, long term is not given, but patients do respond to these short courses. So if there is episodic and the pain duration of that patient is around 8 weeks, you can only go for steroids. There is no probably need to give verapamil per se, 60 milligram for 5 days and taper it down 10 milligram every 2 to 4 days. Gon block is also a very efficacious method of treating this tide over period. And both betamethasone and 80 milligram MPS can be used for the same. I thank you all for your patient hearing. Thank you.
Thank you, Ashwin, for a nice case. I think it is open for discussion. Is there any questions or answers anywhere? I don't find anything.
Actually, I have a question.
No, we will ask you. Don't worry. We will ask you a question. Right. Any questions from the panelists?
Any role of sphenopalatine ganglion radiotherapy ablations in
Actually, yes.
Any role there in the cluster headache or in the temporal cephalgia? The important.
Actually, yes, sir. There are conflicting reports about the same. For the same case, I did search the literature for the same. There was a case I report that I don't remember, but they actually did a sphenopalatine ganglion gamma knife resection there, and they said that it has made it worse. So those people recommend to not go for the same, but there are conflicting results, and people have tried not only sphenopalatine ganglion blocks and resections, but deep brain stimulus has been also tried, non-invasive stimulation of vagus nerve and Retrooccipital nerve has also been tried.
Okay, so let me start with this case, Ashwin. First of all, why was this tooth extraction happened? You said that there was no pain before.
He
Why
had
was
some caries. He had some caries and a very localized pain at that point. He did not have any trigeminal neuralgia or a cluster-like pain. He was very categoric about it, because I asked this question to him repeatedly, whether you had some radiation, something, for which it was done.
Right, right. So the point is that, I mean, I would like to take that with a pinch of salt, because I have a lot of patients who actually present, the cluster headache patients who actually present with the onset in the facial region. So their pain starts at the V2 or V3 and then goes up. And these are called the facial variants of cluster. These have been described in migraine also, the facial variants of migraine also. And so this is not really uncommon if you have the overall clinical picture that the pain lasts for about 15 minutes to 180 hours, if they are repeated multiple times in a day, if they are cranial autonomic symptoms, if they are restlessness, and there is a pattern, in this. So therefore, most of the time what happens that any pain that happens in the facial region, there is a tendency by the physicians to label it as a trigeminal neuralgia. So in your patient, there was no neuralgic component at all, right? You said that the pain was just a type which was ascending up, and then it went on to involve the periorbital area. I can show you a video patient of mine with exactly the same kind of thing which you are describing. In fact, he also had an extraction, and because of this pain, and he had, he would put his fingers like this at the onset. The cluster would begin like this as a pointed area where the tooth extraction has happened, and then it would, because nobody is bothered later on that what is happening to the headache part. So it is often missed, and therefore I would like you to again revisit and ask the patient that what was actually the pain type, and that is one part. If we take that it has followed the procedure, right? If it has followed the procedure, what that is, but before that, then the combination of the cluster and tick. Now, cluster and tick is a very, very interesting entity, because in this, the cluster pain attacks are also superimposed by this tick-like, the neuralgic component of the, trigeminal neuralgia. So there has to be so whenever the patient of, cluster headache patient, also the pain character is not described in ICSD. But most of the patients, about 50 to 60% of patients, will describe it somewhat neuralgic, because they will say that, it is shooting or stabbing or electric current light, because they are loss of words. The pain is so severe that they are often not able to describe the character. But if there is an additional component where there is a facial component in the pain shoots like that, like an trigeminal neuralgia, then you bring in the concept of the cluster tick, right?
If I can just, once, basically what happened, what actually happened to that patient is that it started in the upper maxilla. It follows a straight line to the lower jaw. Then he says it traces the lower jaw up to the back, and then it turns around. So that,
so patient use a lot of this kind of descriptive languages. So you have to really know that whether there is a short electric shock-like current sensation in them. So therefore, it is unlikely that this was a cluster tick syndrome, because the phenomenology, the phenotype is not suggestive of that. Now, coming to that, whether this is something which happened and triggered by the operative intervention. That patient did not have any headaches before or any pain before, and now this has happened. And so that there are a lot of endodontic procedures. They are followed by facial pain. A lot of people come, right? Okay, doctor, we had this operation, and then following that, we are having this neuralgic pain. And that, as you rightly said, that most of the time it is because of the pulp, those free endings getting crushed or that is getting damaged, right? But they generally do not lead to a cluster-like phenotype. They would not, generally lead on to the cluster-like phenotype. Now, what happens that if the patient does develop a cluster-like phenotype, then obviously it does not become a primary cluster headache. Then obviously you need to talk it about as a secondary cluster headache caused by an intervention, right? And as you showed that there are a number of reports, especially this is coming from, the groups which are not so well versed with the cluster headache phenotype. So there might be a lot of some features which might be cluster-like, but it does not really fulfill all the criteria laid down by ICSD for the cluster headache. So it is better to call them as a cluster-like headache, right? Cluster-like headache because of, these kind of, whatever you may say, the operative procedure or some secondary, components. There are a lot of conditions in that. There is a huge list of that, and starting from a meningioma, paracellular tumor, everything can, kind of is listed, aneurysm, acute infarctions, all sorts of things have been described to produce a cluster-like headache. We have to believe that there is a kind of a pain pathway which might be responsible for the uniqueness of the cluster headache. Well, because it is the same trigeminal system which is used for migraine also. So why the cluster headache patients are different? In fact, I would request you to refer to a recent article by Goldsby et al., which was published in, I think, 2 months back, which suggests about the connections and the networks. So they actually showed that the networks actually are activated are different from the migraine period. So this is a preliminary work, but it does suggest that lies probably the difference, that why they behave so differently than the migraine headaches, right? So therefore, I think that overall, I would say that this is a cluster-like headache, right? And whether this was actually triggered by this or it was present, that you need to again relook at the patient and, kind of find it out. That is one point. Now, as far as the treatment part is concerned, I find that your dose of verapamil is too low, right? You are giving only about 360 or something like that, So this is again a message to everybody. Whosoever is treating cluster, please do not hesitate to move up to verapamil. Don't, worry too much about the heart blocks. It really happens. And if you are going to do, I prefer to not, as per the recommendation, that when you go up to 540 or something like that, then you start doing EG. No, every increment of 80 milligram, you do an ECG and see that whether what is the heart rate, what the blocks are developing or not. But you can easily go up to, and normally in our setup, we are going up to 720 without much problem, right? Especially in patients who are having a chronic cluster headache. Chronic cluster headaches are very difficult to control otherwise, right? Number 1 point. Number 2 point, if you want to add on, then in chronic cluster headache, especially you would like to add a lithium, right? Because lithium has been shown to be more efficacious in chronic cluster headache than the episodic cluster headache, right? Now, as far as the Gon blocks are concerned, if you are giving Gon blocks with the steroids, then you give that instead of adding up oral prednisolone as well as the Gon block, because both are actually not it is a thing, because in Gon block also the main action is through steroids, and oral steroids is also essentially you want to avoid the systemic side effects of steroids. That's why you are giving Gon block, and the effect is, in my opinion, is faster in Gon block rather than. You can repeat the Gon block. There's no problem in 1 month. Now, the study by the Leroux et al. Has, in a randomized trial, have shown that within 2 to 4 days, you can give 3 injections if the pain persists, right? So you can call the patient. So what we follow here is that we follow every 3 days. Every 3 days, we call the patient. If the pain persists, then we can give another Gon block, up to 3 Gon blocks, right? If by that time the patient does not respond, then we will take it that the patient has not responded to Gon block, right? Then we have to have other measures. Now, the next point about the sphenopalatine ganglion. The sphenopalatine ganglion, now there is a randomized trial which has shown that if you have an external stimulation of the sphenopalatine ganglion, you can put a chip in the sphenopalatine ganglion and do an external stimulator. There is again this trial by Goldsby, and that has shown to be especially good effective for episodic cluster headache, right? And also to some extent to the chronic cluster headache. But the problem is that you need a ENT help for putting that chip in. That is not available in India to get it imported from outside. And the third thing, even if you want to, you will not get it because the company is busted now. So the company was making it, right? There is a talk of rejuvenation. So some other companies probably taking up. So in another 6 months or 1 year time, you'll probably start getting that. Now, as far as the other modalities are concerned, that one can give a sphenopalatine block by giving through the nose. There is a special catheter that is available. Some people have used it. I have not personally used it much, but it can be used. As far as the ablative procedures are concerned, they are not to be recommended because, as Professor Ganguly asked, because what happens that there is an initial relief, but the pain returns. So most of the ablative procedures, the pain returns after some time. So you generally do not use an ablative procedure until and unless it is really chronic and it is really troublesome. Even then, also the evidence base is very low. Now, the recent development, if you are treating with such patients, is that the best drug probably would be using galcanezumab in these patients. So there is a trial and there is a follow-up trial, right, in which initially the dose was suggested as 300 milligram, but now there is a follow-up trial, even 240 milligram is good enough. So that can be used. In fact, in the West, where they are getting through insurance, this has become the standard care for cluster headache for most of the patients. Again, using the same kind of a schedule. So I think that overall, the tax present always this kind of a dilemma that what is it? Is it really tax? But if you are having so significant clinical features that short duration headaches, they're associated with autonomic symptoms multiple times in a day with restlessness, then you have a cluster headache in hand. So that is my take on that.
Thank you so much, sir. It actually helps sort out two major issues. I think, yes, cluster-like headache, but I'll go and revisit and I'll get back to you whether it was actually a post-endodontic.
Yeah. So I think, many a times what happens that people want to, and also you see that what happens that if you get these procedures done, there is always a delay after the procedure of reporting the recurrence of pain, because most of the patients, when they go in for this operative procedure, they have such a high expectation that because of the placebo effect itself, the procedure will produce some effect for week, 2 weeks, and then the pain returns, right? So most of the people will say, no, doctor, it had some effect and it was all right for 2 weeks or 1 month, as is shown in the figure that it starts from 1 month to some 52 months or something like that. Right. So similarly, because of this, kind of a placebo effect for pain, any procedure would, might, I not say invariably, but might actually produce an effect which the patient thinks that the procedure has benefited, but the soon that evaporates if it's a, it's a placebo kind of an effect. Similar with the, kind of a specs in migraine. If when the patient comes and goes to the ophthalmologist, refractory error. So initially for a period of about few weeks to a month, there will be some relief in the headache, right? Invariably, you ask these patients, they say, yeah, initially after but then the headache started coming because the ophthalmologist thought it's only refractory error, but we know that they are not refractory errors there because of the migraine, right? So I think always at any invasive procedure which is done for the patient, you should always, take it with a pinch of salt because that is definitely going to produce more expectancy for betterment and therefore a good placebo effect.
Thank you, sir.
Mm-hmm.
It's always nice to get clearer insights from you. That's why that's the reason for present this case.
No, that's a very good case, and this is a dilemma, but it is still possible. I am not negating this thing, the possibility that this procedure.
That is what I wanted to ask you whether you would, because the dental papers, they actually mentioned somewhere while searching for this literature said every facial pain unless and until proven otherwise is dental in nature. I understand that everybody has their own.
So I will again tell you that there is a large group of pain medicine specialists with a background of facial-maxillary expertise, so dental surgeons and other pain specialists, right? And there is a group of people who have presented just like ICHD3, entire classification of peripheral origin of these pains, right? And they have in there also you will find the facial pain mimicking cluster. There is a condition like that, right? Cluster like headache due to or facial pain due to cluster, something like that, right? So I can send you that copy. I can circulate in the group also that PDF. So you will amazed to see that, and that has been published in Cephalalgia. It's not that they are published in less reputed journal. So there is again a strong lobby of the peripheral origin of pain, and as you have suggested in your pathophysiology. But since there are very, very robust evidence of the central features. Like we have now fMRI, we have now a lot of network studies that are available, and there are a lot of hormonal studies, there are a lot of electrophysiological studies which have shown that the pain is probably generating at the central level, at the hypothalamic level, and of course the peripheral levels can trigger it, and therefore it is a kind of a thing where, just like in migraine, it can be that there is a peripheral pathology also and there is a central pathology, but the triggering factor is probably the central and the hypothalamic region. But interestingly, earlier believed that it is only the hypothalamus that was involved is not now fully endorsed by many. They think that this entire activation of the pain pathway through hypothalamic nuclei, because hypothalamic nuclei has a strong connection with the pain pathway, and that probably modulates, and that is responsible for the also the cyclical nature of the pain. So there is a modulation when the pain, the hypothalamic activation lets the brainstem affect the person to allow the pain input to go in or disallow the pain input to go in. So there are a lot of papers on that. So I think overall, we want to treat the patient, and I think that when you go full throttle, right? Don't be in a half throttle mode, right? Because chronic cluster is a very devastating thing. And in this case, if you are sure that the patient did not have any pain whatsoever before this, then you can say that this is a cluster-like headache triggered by a endodontic procedure.
Thank you
That
so
would
much.
that would be a reasonable stand.
So there is a question. There is a question in the chat box by Dr. Archana that are there any recommendations for orthodontists to prevent this triggering a cluster headache or a trigeminal neuralgia?
Who can talk to the surgeons? It's very difficult to talk to the surgeons, right? And you always feel that I'm always humbled by them. They are doing such great works. Only when the patient lands up in chronic pain and where they cannot do anything, they send it to us. So we have to bear the brunt, unfortunately. And you, Dr. Archana, you must be seeing a lot of patients with this, broken tooth, extracted tooth, multiple operations, not only one. I have one patient who has got 3 teeth extracted because of thinking of a trigeminal neuralgia, but it was a case of Sankt and Suna. So that happens. We are lesser mortals, so we cannot give any recommendation to orthodontists. Right. Any other comments? Okay, so Ashish,
Any role of stimulation devices for cluster?
I mean, you mean that the peripheral stimulation that has come? No, in cluster, yeah, gamma core is helpful. Gamma core has, again, it has been found to be more helpful in episodic cluster headache. But I am not, I don't know that I have read about this REN device for cluster. I have not really gone through, but maybe that they might have started some treatment or not. I really don't know that, but definitely gamma core is this thing. I think for the chronic cluster headache, you need to have a very difficult patients, some at least I think 5% of this chronic cluster headache, of the chronic cluster, which is rare in India, but even then 5% of that may be totally refractory to what you do orally and by other means. So in that case, you would like to intervene. So you give the Gone block. If they have partial response to the Gone block, then the occipital nerve stimulation invasive is the best available evidence so far. People have gone in for spinal cord stimulation. People have gone in for DBS, but those are very, very invasive and life-threatening. That can be life-threatening complications. So therefore, that are not to be recommended. Occipital nerve stimulation is relatively simple, but the problem is that again there is a problem of lead migration and infections, battery kind of thing. So it is also not very popular amongst the headache specialists, but it is one option you can give for the refractory chronic cluster headache. But I think nowadays with the combination therapy, you would fare much better. And I think by end of this year, Galca is going to come to India, and even now we can get it, albeit in a higher cost. But that will, if you combine that in chronic, I think that will be at least two of my patients are on Galca and Verapamil, this thing. So therefore, stimulation is either invasive or non-invasive. Invasive is always last resort. Non-invasive, the gamma core is one. Two patients of mine have used gamma core. One of them actually benefited significantly, and one of them had a decrease in intensity of the headache attacks, although the total number of attacks did not respond so much. Then we had to give repeated gon blocks to break the cycle. So generally, this is the state. So I think another thing is that because all of you are here, so I would request everybody to participate. I think we need presentations from everyone. You all are seeing good clinical cases. You kindly make an effort to present cases. Sucharita, you are here, so I think you should now present. You are back from your lovely holiday at in Canada. Now you must work now, and you present cases. Similarly, others also, right? We should have. Professor Ganguly, what do you say?
This is a beautiful case presentation. I think last case you discuss widely.
Right. So, and I think, I think more newer people, younger people, they should present.
Yeah.
And also, Ashish, make an effort to make more members. You are not pushing the hard. Whatever I have left, you have kept keeping it there. Increase the membership. Tell all the youngsters in your institute, my institute, other institutes, everybody should encourage to become a headache subsection member.
Yeah. So I also told my students.
Right.
The headache.
Right, and soon we will be. I just attended the American Academy of Neurology meeting, and there I had a lot of discussions with them, and we are going to start some observership and fellowship programs also. So be in touch, be in connect, so that you can benefit from that. We will advertise through IN's portal, and so people can actually avail of that. That will be good opportunity. Okay.
Yes.
Okay, then we call it a day. Ashish?
Yes. Yes, sir. Thank you.
Right. So thank you very much, everybody, for joining in. And I think you have a very good night and coming days in the week. And hope to see you again in the next meeting. Thank you very much.
Good night, sir. Good night.